Bien, buenos días, bienvenidos a todos, gracias por vuestra presencia. Good morning, everyone. Let me introduce today's speaker. It's a pleasure to introduce Dr. Karpanda, who is visiting the center. Dr. Karpanda, he is a cardiovascular and interventional radiologist. He's a Director of Research Sciences and Strategic Directions of the NIH in the United States. He was Chief Medical Officer at Delcath Systems in New York. He works in a combination of devices and drug treatment for cancer in the liver. And he was professor and chair of the Department of Radiology at the University of Massachusetts Medical School. A radiologist in chief at the University of Massachusetts. He was at the Biomedical College of Cornell University. He was professor of radiology and chief of service and director of the Division of Cardiovascular and Interventional Radiology at the New York Presbyterian Hospital. He has a very big career, academic career at Harvard. He started at Harvard Medical School. He was an associate professor of radiology, director of cardiovascular and interventional radiology, and the Vascular Center in Boston. And he was also on the faculty of the Harvard Massachusetts Institute of Technology, Health Sciences, and Technology Program. Dr. Karpanda, thank you very much for your visit. Thank you very much for your time. And the audience
is yours. I'll just walk up there.
Yeah, thank you very much.
Thank you very much for coming to this lecture and for the nice introduction. I'll only make one correction. I'm the director of the National Institute of Biomedical Imaging and Bioengineering, the Direct Research Sciences, not the NIH. Our institute is 1% of the entire NIH, so I don't want to make a big claim here. So I have organized my lecture into, several parts. So I always speak to mixed audiences, so sometimes there are experts who know more than I do on the topic, and then there are people who don't quite understand what I'm saying. So I'll try to find a happy medium there. So the National Institute of Biomedical Imaging and Bioengineering is pretty much a mirror of what you're trying to do here. Our vision is to engineer the future of healthcare. The mission is to develop accessible, cost-effective technologies for disease prevention, diagnosis, treatment, and prolongation of healthy human lifespans. I know we can keep people living forever, but that doesn't necessarily mean they're happy and are aware of being alive. Now, we play a very unique role in the NIH for the other 99%, and that is we're the Innovative Technology Development Center. We take technologies and we see the convergence between technology, science, and biology, and try to come up with products that improve patient care. We have recently started what is known as a beta center, which is an actual hands-on prototype development for any institute within the NIH that wants to try to do something. That is so we have an intramural, which is inside the NIH research, and we have extramural, which is outside the NIH. And most of what NIH does is extramural. In other words, we review grants and we give away money. So I will tell you about some of the extramural programs we've supported, which fall into line with what you're trying to do here. So we have 4 areas that we're interested in technology and innovation. One is imaging, of course, that's the primary area, and the other is therapeutic devices. We also have sensors and point-of-care technologies, and we have engineered biology. Now, I will not talk so much about point-of-care and engineered biology. I will focus more on the imaging and therapeutics in keeping with the mission here, which is minimally invasive therapy. Now, we tie all of our interests together with computational modeling, data science, and machine learning. So no matter where, we can take all the data and we try to combine it to produce something better. Now, we're not perfect. That's our ambition. And sometimes, and we've achieved a lot, but there's still more to be done. In the area of engineering medical imaging, we typically will give grants for improvements in radiography and angiography, ultrasonography, CT, the usual things you're used to, radionuclide imaging and magnetic resonance imaging. Lately, optical imaging, because our new director is an optical imager. And we have an intramural program in microscopy, but I won't say much about that. So we find that the trends in medical imaging are usually the scanners are getting faster, they're getting smaller, less expensive, better, and the whole idea is to make it more accessible. Even in a country like the United States, there are areas of the country that do not have regular MRI scanners and so forth. It's different in the big cities. I remember I once went to England, I think it was in the mid-'80s, late 80s, and they were talking about MRI scanners. And in Boston, which was known as the Longwood area, which was Harvard Medical School, we had 10 MRI scanners at the time. And they were telling me in England, all of England had like 7 or something like that. Now, of course, the whole world's got them everywhere. We're into multi-scale imaging, as I said, I mean, from the microscopic to the macroscopic. And we try to do this. And when I say we will not fund anything that is a copy of something else, or just an incremental improvement. It's got to be something really innovative that changes the field as much as possible. So when we're asking for all these extramural grant proposals, we will look at to see that the image quality and is not compromised, and the quantity of information that we gather is great, so that that's the information that we can use for further uses, such as artificial intelligence. So one of the things is that you already realize we're going from a strictly anatomical diagnosis for more functional imaging and motion in radiology. I mean, it's been coming, and we've all realized that. Also, it's not just image-guided procedures, but information-guided procedures. We take more than the image into account. And the image can be in many forms. It doesn't have to be just X-ray or MRI. It can be light. And then all the data we're gathering, we've got to do something with it. And it's the dawn of artificial intelligence, as you all know. So we want to get these machines to understand what they're seeing with so much data. So we want to be able to collect all that data and make some sense of it. Now, you can have simple machine learning. Artificial intelligence is a big word. I mean, simple control systems in your car are artificial intelligence. But it can go all the way from a simple control system to segmentation, lesion detection on an image, and finally, if you go into the really deep learning, which is a complicated subject and probably for another topic, you can go well beyond what human beings can understand, and that's when the problems start. And I think here in Europe, you have a much better handle on regulating that kind of artificial intelligence of the future than we do right now in America. Right now in America, everybody, that's what they want. And only now are we beginning to talk about regulation. Now, since I said we're going to functional imaging, I'll show you an example. This is the kind of thing we would do. This is Dan Sodikson, who's at Columbia in New York, and his colleague Zhang. They've created a glove coil which has high impedance flexible elements built into it, and the person just puts their hand in there, and you can actually visualize the motion between the fingers, off the fingers, so you can see here. And this sort of technology can enable the assessment of joint diseases and maybe perhaps even muscular function and so forth. It's in its embryonic, but it will find its way to larger joints as well. That's the one scale, that's macro scale. To the micro scale of gathering information and motion is this very interesting technology, I think, and that's default mode networks. Default mode networks are the networks within the brain that are working, perhaps when you sleep, when you're awake, but you're not voluntarily doing anything. So if you're just sitting there and daydreaming, the default mode networks are trying to correct the brain, readjust it so it can work for the rest of the day, sort of. So this technology is made to detect default mode networks in the fetus in utero, and it basically is looking at the functional connectivity of the nerves even as the fetus is moving. I mean, so they have to do a lot of motion compensation, but they have. And what this will allow is, of course, it'll allow adult diseases, because once you know the default mode networks, when they're kicking in or not, often problems in autism and Alzheimer's disease. But in utero, it helps you look at the developing brain. And you can also tell how the brain is being affected by external disturbances like the environment, or even mothers and nutrition, genetics, and other infectious diseases. So to show you, this is the MRI of a uterus, twins, it turns out, and they'll take the scan of the brain while in motion, and they can create a 4D fMRI image. And what eventually is they get an average of brain development over the 32 weeks, and they can tell if the brain is developing well or not. But most importantly, they map out the default neural network, which is important in itself to study fetal brain development. So from that, we go to smaller scales. From the baby who's in the uterus to the baby who's now born and was moving all over the place, and we need to do an MRI scan. Now, as you all know, whoever's done baby scans, they move a lot. We try not to sedate them. It's not a good idea to over-sedate them. So this is a coil that basically coddles the baby, holds the baby still while you're doing your MRI scan. It's a very clever idea that came out of Berkeley, the University of California at Berkeley, and it's very useful for imaging little babies who cannot stay still. We're also, of course, we're looking for less expensive. We're not only for use within the United States, but for other parts of the world where they may not have access to some of the technologies. This was, the NIBIB sponsored this through the General Electric, and it actually won a Popular Prize magazine in 2010. It's a handheld scanner, and this is the scan. You've seen it now. I think everybody's got one in the emergency room. And it's also it replaces basically what a larger scanner, which is about $150,000 to $200,000, with something that's about $8,000. And this model that you're seeing is even bigger than the ones that are currently available. The currently available ones are like cell phones. And not only that, you can put into these systems the artificial intelligence you need so the scanner will tell you what projection to look at the heart at. So, I mean, even if you don't know that you want to look at the septum, it'll tell you, well, if you turn your scanner around a bit, this is where the septum is. This is just a picture of a kidney, obviously, there. So this is one we will sponsor. And then there's MRI scanners, which, as you all know, are very expensive. An MRI is not available around the world, obviously, and you need something at a lower cost. And so this is another GE Mayo Clinic proposal where they thought they'd build a system to study heads, extremities, and little babies, and also make it small enough that it can be used in the battlefield for traumatic brain injury during sports and so forth. And it uses a very little helium, which is one of the major costs rather in an MRI, and also a risk operationally. So this is the scanner, and these were images produced in 2015, and in comparison to a 3T connectome machine is sophisticated enough. Now they're even higher. They're basically looking at mapping out the neuronal pathways within the brain. So this machine is doing almost as well as that in terms of performance, but it's also 1/4 the weight. It uses less than 1% of the helium, which is very economical and doesn't need as much space. Now, I'll talk a little bit. I know I'm jumping around, but purposely so to sort of show you the variety of things we try to do. And in terms of increasing accessibility, not only for imaging, but for other systems, here we have, for example, those of you who have children know that every child gets middle ear infections called otitis media. So this is a handheld optical coherence tomogram scope that can tell you, let's see if I can, oh yeah. So this is a normal eardrum, very thin, flexible, and this is abnormal, very thick, and then it's not too flexible. So you can tell in kids very quickly if they have otitis media or not, as opposed to other means which are more cumbersome. This is a smaller scale. I think I'll show you besides in utero imaging, and this is called microscopy based on ultrasound surface excitation. Ultraviolet surface excitation. So you use ultraviolet light reflected onto the surface. This is a little module that fits right on your iPhone. The specimen itself that you put does not need any preparation or any sophisticated lab. You can just sort of cut even a 0.5 millimeter thick, and then you can get the kinds of images that are shown over here right into your smartphone, and then if the person doesn't know how to diagnose it, obviously you can send it to your local hospital. So these are the kinds of things that we try to encourage in terms of use in places that are not as have less access to medical care. So we've talked about MRI scanners, and those of you who know about MRI scanners, they're superconducting magnets. They need helium to cool it down. You have your huge gradient coils, the gradients that encode the spatial information of the body. And all of that is very expensive and very hard to do. There's a lot going on there. So this is something that was proposed by the Massachusetts General Hospital, Larry Wald. And here we have a scanner that's based on permanent magnets. They're cryogen-free. That means they don't need any cooling. They're permanent magnets. They're like plates, and they rotate. And the rotation of the magnetic field is how you encode the message. In other words, you know where the heart is, the liver is, without having to have a spatial gradient, as an imposed spatial gradient on a supermagnet, for example. So this is... It's still being developed. It's only 300 pounds. It's a head scanner, but it can move anywhere. 300 pounds is nothing these days, and possibly even into space. Some of the things we think about are lightweight and small are also intended for maybe when we get into space, and I'll show you some examples. I mean, that ultrasound scanner I showed you, the handheld, has been used on the International Space Station. And it's also been used by the Vatican in Congo, for example. I mean, they just gave them away because they needed to give them quick diagnoses. So these technologies, when they develop, do find their way into areas. This is something that might be of interest to you, and this is the ultrasound patches. They're very thin ultrasound sensors built into a flexible patch. I'm not going to go into the details of the layering, but they can create exquisite images. Here, for example, this is a B-mode apical view and a parasternal view. And WI means the wearable imager, and CI is a commercial imager. And you can see that the difference isn't that big at all. And you can also get a B-mode segmental view to look at ventricular wall function. And at the same time, you can measure the displacements. You can get M-mode images, all of this with a patch that just stays there. So in other words, the patient can be on a bed, and these images will be obtained by the ultrasound scanner. Of course, it has to be connected to the computational part of the scanner, and that can be transmitted to the nurse's station or whatever you want. Or you can do it for example, if the patient's home, and you want to see developing chest pain or whatever, you want to do a quick echo, you can do it right there on the spot. And I'm speculating on what can be done with such technologies, but they are being developed. This a little bit more into what's going on in imaging. In terms of imaging, we're trying to improve the characterization of tissues. We do that obviously by contrast. We give contrast injections. We know, where the tissue is, where the blood vessel is, where the vein is. But we also want to know about the mechanical properties, textures of tissue. It's very important obviously for understanding disease and for treatment. And all of this information that we gather becomes, we call it fodder, or fodder is what cows eat, for precision diagnostics and artificial intelligence. So let's look at composition first. Now, normally, if you to do intravascular ultrasound, if you were to do intravascular ultrasound and then do an intravascular optical coherence imaging, you'd have to use two different catheters. It prolongs the procedure time. You can get exquisite resolution on the OCT, 60 microns, but you can only see 60 microns of the blood vessel versus with an IVUS, you can see the whole thing, but the detail and resolution's bad. So what if you were to combine the two? Right now, the normal technologies for ultrasound at 30 frames per second, that OCT is much faster, but it's this, the weak link in the chain is IVUS. So this is actually my current boss, by the way, Bruce Stromberg's lab. Before he came to the NIH, they came up with a high-speed IVUS OCT catheter. It's one catheter that has both technologies. It has a frame rate of 72 per second. It can image a 72 millimeters segment of vessel in about 4 seconds. What this does is only one insertion, you take it out, the risk of complications and spasm goes down immediately. And here are the images that you can get out of it. Here he's showing, here's your IVUS image, seeing the full thickness of the wall, and the OCT showing just the fibroma, the atherosclerotic fibroma. And of course, they've done studies and comparisons, and I believe clinical trials are ongoing. This is called infrared optical frequency domain imaging, the blood vessel again. Maybe you have these technologies here, but this gives you much more resolution. What it does is, because of the birefringence, you can actually tell what the components are, such as not only fat, but cholesterol crystals, as you'll see in the lower image right here. So that is very, very powerful. Again, this is being done at the University of Utah. So all of these people, and look at the in-plane resolution, it's 10 to 20 microns. It's very good. And an axial resolution is only a 2 millimeter segment, really. I'm sorry, not 0.2 millimeter segment. So this is exquisitely useful information when you're looking at plaques. You may not do this on every patient, but certainly for research purposes, it's very useful. In terms of texture, I think the NIH has to be proud that we sponsored what we call the photon counting or spectral CT. Some people these days call it color CT. The color obviously is artificial, right? So what in a normal CT scanner, you have one energy that you look at in a little voxel, and there's not much information. These scanners, what they will do is they look at all the electrons and all the energies coming in within that little voxel, and they give you a spectral signal within the voxel. So what it can tell you is it gives you information on the local composition and texture. The other added advantage is there's less signal to noise. There's less electronic noise. There's much better signal to noise and spatial resolution. And you can really, because of its special qualities, you can tell the edges of contrast edges much better. So here, this is just a person who's had an intravenous injection plus some GI, barium or something there. So what you're seeing is that the two different contrast agents and how they appear, and you can see the liver sort of pinkish. Again, as I said, it's color-coded based on textural, the minuscule textures that this technology is able to give. At the present time, they're developing more contrast agents that can be used, and it's certainly much more information than normal CTs. And by the way, it's commercially available now. It's been available for about 5 years, I think. Now, we're also interested in tissue mechanical properties, and we all know in atherosclerosis, the coronary arteries get stiffer, and we know that by doing ultrasound. We do carotids, we see the stiffness of the carotids and so forth. But you can get even more than that if you actually look at it. These are abdominal aortic aneurysms, which, basically, for those who don't know, it's a bloating of the main abdominal aorta. It becomes like a balloon, and when it becomes big enough, it'll rupture. There's a risk of rupture. So today's practice is, you follow it by ultrasound, and once it gets greater than 5 centimeters, you might say, okay, well, the person needs surgery or a stent or whatever it is. But by studying the actual mechanics of what's going on in the wall, you can be much better at what you do. For example, here, you're seeing a soft aneurysm. They're both the same dimension, right? Both are 4.7. But this one is soft, growing at 0.1 centimeter per year, and this one's stiff. I mean, this is growing at 0.6. Now, anybody who's an engineer, and by the way, I guess I told Willie I'd tell you what, my background is in aerospace engineering. Then I became a computational fluid dynamics person to get my PhD, and then I went to medical school. So that's why I'm very interested in an engineer. So what happens is in anything in engineering, when you have discontinuities within the material, that's the point of weakness, and that's where the fractures start, whether they're bridges or airplane frames or wherever. And the same thing applies, of course, to a stiff aorta. So what you can do here is you can look at it, measure the strain with ultrasound, and say, well, this does not look like a healthy aneurysm, and I'm going to operate on it, even if it's only 4 centimeters, because it's not going to get any better. So that's the kind of technology we're talking about. This you probably have heard of. Here again, the excitation is using ultrasound. It's magnetic resonance elastography. And once you've disturbed the liver with ultrasound, you detect the signal with MRI. So you can get a sense of where the liver is fibrosed. You can also, obviously, you can see an image. For example, if you were to do this in a brain, and you're looking at a tumor, you can tell where the edge of the tumor is, whether you can actually take it out or whether it's intricately connected and adherent to the brain. Now, so again, going down even deeper scale, and this is looking at angiogenesis, which you all know is a culprit both in vascular disease and in cancer. And the common way of doing it is FDG PET to look at glucose, basically glycolysis imaging. And Sean Chen, who is in our intramural program and the editor of Theranostics, he's unfortunately left, but good for him, developed the 18F-alpha-tide, which binds to integrin receptors. And these are receptors that are overexpressed when you have angiogenesis. So, for example, here you can see an RGD image. Let me see. Okay. And in every area that you see, other than this is just bladder and stuff like that, but the METs, those are areas of active angiogenesis, okay? And this is the FDG, not so well seen, because there's no glycolysis occurring in that. Now, here, to establish, here we have an acute infarct in the anterior septal defect on the FDG image. That means there's no glycolysis going on there. But you see that in the RGD image, there's angiogenesis. Already the heart is trying to repair that. Similarly, that's an acute MI. In a chronically diseased patient, there's you will see that FDG, there's glycolysis, but it's very absurd and not uniform. But when you do the RGD, there's no angiogenesis, right? I mean, it's chronic. There's no more repair occurring. So that's one. And then the same thing in brain here. You have an occlusion of the middle cerebral artery there, hypoperfusion of the FDG. Contrast enhanced shows a bit of an anterior horn infarct. And then you do the RGD, and it looks like it's already repairing itself. So there's more information here. It's not just, well, you have a stroke, but it's a stroke that's fixing itself. And then you can use even more fancy technologies such as ultra-fast photoacoustic microscopy. Photoacoustics, for those who don't know, and I don't want to be insulting, what you do is you do an ultrasound. You use ultrasound to disturb the thing locally, right? And then the photons get heated up, and then they send back a signal, and you pick up that signal using you pick up the light signal. So it's really optical imaging, but the induction is through ultrasound. And so here they're studying a normoxic brain. So the technology is sophisticated enough that you can tell hemoglobin that's got oxygen in it and not. Because you can also tell motion. So this is a hypoxic brain. It's only color-coded again. And because it can tell the edges of the vessels, it can also tell you if there's a constriction of the vessel or not. So there are two things you can get, not only the oxygenation, but also the mechanical state of the blood vessel. Now, we also have a program in nuclear medicine and PET. And as you know, you've probably heard of the 7T connectome machine that I think we pay for. It's at the MGH, and it's basically trying to get all the pathways of the brain. We don't necessarily understand what's going on, but we're at least getting a map of what it is. That's the first thing you do. And you can improve the information by inputting in a SPECT, a brain PET insert. That's nuclear medicine imaging. In other words, you can look at function around these nerves that you see connecting. So this is an insert for the 7T MR magnet, where you can get radionuclide images with resolutions of 1 millimeter and sensitivity much higher than 10 times what you'd normally get compared to PET cameras. So this is again going to tell us not only form but also function within the brain. The other trend is sticking to radionuclides is that alpha-emitting particles are being used more and more for treatment of cancers. But the problem is controlling the dose that spreads from these particles. So this is a multi-isotope scanner. In other words, you can put in the imaging isotope and you can put in the treating isotope, obviously experimentally, and then you can say, okay, this is the extent of the image on the imaging isotope, I want my treatment isotope to go to that entire area. That's the principle behind this. And obviously it's got applications in oncology, cardiology, and neurology. Now, that is the multi-isotope scanner. Now, this is just a regular single-photon imaging for alpha transmitters so that you can optimize doses. This is for animals. This is where you can optimize doses, as I said. You can do your studies here, and then you can apply them to humans when these technologies are ready. They're not ready now, but that's the idea behind this. Now, since we're all interventionalists here, I mean, I can't go without saying this is actually Steve Hetz at the University of California in San Francisco. This is him right there. You sit outside the MR scanner, and all of your controls are on the outside, and he has a foot pedal to do what he needs to do with his catheter. So this is the catheter that's been placed, and by passing a current through the tip of the coil, that's an artifact. Okay, so you can remove that artifact later, but here you see the artifact. You can divert the wire to go where you want it to go, just like you would on angiography. Now, I'm not sure how far Steve's taken this, but I know I've had a long-time interest in intravascular MRI imaging, but it's sort of hit the wall because many of these technologies are so much easier and cheaper to do in an angiography room, and you can do it quicker, and people are just not used to it. They don't want to put the amount of money that this might take. But I think it's, you have to be patient. These technologies will someday find their uses, I'm sure. So going from MRI to light scattering spectroscopy, I mean, again, shifting gears. You know that you probably do a lot of endoscopy here, and this is a spectroscope that's put on the tip of the endoscope, and what it does is it looks at the spectra in 2 different frequencies, and it can tell you, in short, it can tell you whether a cyst is benign or not. Okay, well, basically, it can differentiate a benign cyst from a dysplastic cyst 100%. Dysplastic cyst 100%. But in terms of saying how much more dysplastic is it, it's only about 92% accurate, but still good. So you have a cutoff here, for example. Everything below is definitely is low-grade dysplasia. Everything above is high-grade dysplasia. So everything in red is really high-grade dysplasia by pathology. Everything in the other colors is low-grade, and the pathology agrees with it. So they have a pretty good result. The thing is that it's rapid, it gets done, it's inexpensive, it avoids a lot of pancreatic duodenectomies, and because of its potential to tell whether something is truly benign as opposed to, I don't know, maybe you should do something about this. So, so we also get involved in that. And now, I was just reading on the plane and I couldn't quite open it up. The vagus nerve, I mean, people have always been wondering and excited about it. Now it's even back up again in the press. As you know, the vagus nerve has a lot of functions. I mean, it's like the main highway from the brain to the rest of the body. So there's Larry Miller. He was doing this procedure where he accidentally went into the wall of the stomach and found that he could see the vagus nerve there. Excuse me. And so what he did is he made a procedure out of it. So he then deliberately started dissecting in. And I'm sorry if this takes a little longer. This is a pig. So he's going into the side of the stomach. And you can see that that's him trying to go through. That's the clip where you can clip onto the vagus nerve. There's the vagus nerve right there. And then you can sort of dissect your way all the way into the omentum or up. And you can clip right onto the neuron, and you can take your measurements. Now, will I be a subject for this? I don't think so anytime soon, but it's certainly in experimental work in neurology. I think this is a very good technique to study what the vagus nerve, and to this day, as much as we know about it, we know very little about it. And he sees clinical applications in GERD and gastroparesis, even in diabetes. Obviously, we'll find out. Maybe someday we'll even find out this about renal innervation. So from that, we go to this little capsule that's been Bob Langer from MIT. Bob's very active in a lot of things. And this basically is a capsule that's got bacteria in it that are engineered to detect blood. So what happens as soon as they see blood, the bacteria will luminesce, or they'll sort of light up. And then there's a little measurement of the light from the bacteria, and that measurement is sent wirelessly outside the body. So this is just a capsule you swallow, and you can tell whether there's bleeding. And I suspect bleeding at much lower levels than you can pick up with a GI bleed scan. So, but this could be very useful in people who have chronic bleeding, as in Crohn's disease or other gastrointestinal disorders. Again, if you're interested in any of these people, this is public information. I'm not allowed to. One of the rules of the NIH is we cannot talk about people who are currently funded and working on research. We can only talk about things that people give us permission to talk about. So this is available. Similarly, this may be another area of interest to you, and this is endoscopic placement of a wireless neurophysiology capability. Okay, so you put in this sensor into the stomach, and then you can study gastric dynamics from that point on, neurological signals, waveforms, and so forth. It's very small. I mean, you just sort of go and put it in there. These are the kinds of things we can put into patients when they're ready. Now, remember that in a way, this is the way it works in America. The NIH will fund these technologies. The researchers will then produce the technology. They may come back to the NIH and say, well, I want to start a small company so I can go further. We may fund them, and then they have to go on their own and get funding from a bigger company. Once that is done, you have your clinical trials. Then the FDA has to approve it, and then after the FDA approves it, the CDC has to say, okay, well, the government will actually pay for this. So there are many stages. These technologies are very exciting to us physicians and engineers, but how many of them will actually see the end of the day? Many of them do. And so right now, we at the NIH work very closely with the FDA, as you'll see in the future example. I hope I'm not going too long. And so by having that government work in coordination, hopefully we'll get many of these out sooner than later. So now this brings me to the last part of my lecture, which is our latest, at least my latest interest in at NIBIB. And a few years ago, well, we have agencies like NIH, NASA, FDA. They're called agencies of the government. We all got together. It's called interagency meeting that the White House Office of Science Policy called and said, we want you to tell us how medical imaging in America can improve. So a bunch of us used to go to the West Wing of the White House. We finally wrote a white paper, which I'm sure for the most part would just sit on a shelf somewhere. But I was excited by the medical imaging and medical informatics and machine intelligence part of it. So what I did is I organized a couple of workshops at the NIH, inviting everybody. The other thing at the NIH is we cannot do anything without everybody's got to be it because we get paid by tax dollars. So the American citizen pays us, we have to spend it, we have to justify every dollar we spend. So when we say we want to do this, we want the buy-in of the community. The community say, yeah, this is a good idea. So we had these workshops. We had all the major players meeting, academic institutions, scientists, physicists, some companies, and of course a lot of agencies. And we came up with this idea that we should have a place where we can clean medical images, accept medical images, clean them up, and make them AI ready, artificial intelligence ready, so that we can then build artificial intelligence algorithms on data that has been the highest quality data with some sort of a label saying this is like a CE mark, an unofficial CE mark. We would call it, I guess, a UL mark in the US. So before I go to that, let me finish. So, as I was saying earlier, machine learning can be applied either at the device level or it can be applied at the interpretation and information for treatment purposes. This is at the device level. This is a rapid, free-breathing, ungated cardiac imaging. In other words, you can breathe, you don't need an EKG, the machine does all the work for you. So as you know, the patients with pulmonary diseases and arrhythmias and young kids, they can't hold their breaths for very long. And some of these scans take 1 hour. So the idea here is to enable cardiac imaging without breath holding or gating. And it can be done in 15 minutes. One of the things that the interagency working group came up with is we need more high-value imaging. This is an example of high-value imaging. So the way it's done is, without going into the mathematics, it's all about nearest neighborhoods and things like that. You sort of guess where the heart's going to be the next second and so forth, and then you extrapolate back, and you correct for any kind of aberrant motions during that time. So when you do that, these are all images. You see that the chest isn't moving at all, but you can see that the heart is moving, and you're getting all the information from it. And it's 4 to 8 times faster than the regular cardiac-gated breath-holding scans that you get. And significantly improved images, and the reconstruction times are much faster, about 10 times faster than normal. And obviously, the clinical uses of these are in obese patients, patients with pulmonary disease, pediatric patients, as I said. And also, because you don't have to stick all these things on patients, you can get images, and it makes much quicker and less use of less time on a very expensive technology. So we go from that to the next step is easy. That was with motion. Here, what they've done is they've done a CT scan on a low grade, or whoops, that one, a low dose CT scan. Then on some patients they took high dose or the regular CT scans, and they said, can we predict what the high dose would look like by just taking a low dose? So I give you less radiation, but I can still, through machine learning, predict what you would look like on a better machine. So that's basically what it is. This is the high quality, and this is called the ground truth, and it's been trained through artificial intelligence denoising neural networks, and all the noises, oh, I didn't realize there's a dual function. All the noise that you see here, woo, it's got a brain of its own, that you see that image is much better, and it's all reconstructed. It's a predicted image. Same thing with MRI. If I have a 3T MRI machine and I want a 7T, and this is the same patient on 3 Tesla versus 7 Tesla, it shows you the details so you can see. What can I do a 3T and predict what a 7T would do? So in a similar technology, they did that. They're called convolutional neural networks. You can all read about it. I don't have to lecture you on it. And here you see that the first image on that's the 3T data. This is the 7T ground truth. That was, and the middle is what the machine is predicting. And the machine is predicting pretty well that what the 7T will look like. Now somebody said, well, you know, very soon we'll have 7T scanners. Who cares? But that's not the point. The point is that we can use the 7T scanners to perhaps tell what they would look like on a 10T scanner. And so, you know, you don't have to always deposit the same amount of energy, I mean physical energy, into creating an image. You can do that. You can save yourself pain and risk by using artificial intelligence. This is another ultrasound. You know, it's just everywhere these days, right? The one thing that it hasn't been able to do is it hasn't been able to tell us too much about the finer texture. So here, what they call a quantitative ultrasound is really a statistical information on the texture of that you see. So here, if this doesn't move, yeah, you have going from here to here, smaller and smaller beads. I'm sorry, decreasing size of glass beads. So you're doing ultrasound, you'll notice that it as the signal that you get is very sensitive as the glass beads go down in size. Well, you get the biggest signals because what we're talking about here is a length that's less than the ultrasound wavelength. Okay, so you can quantify what the dimension you're looking at, the micro dimension you're looking at with this technology. They use this, and basically, I'm not going to go much into it. They oh yeah, this is much better. They're looking at the lipid levels, 3.1%. This is a high lipid level. Okay, so they can tell fat. The next thing they want to know is, can you tell the difference between fat and fibrosis? So what they basically, to summarize the slide, yes, you can tell fat, but this technique is not sensitive to liver fibrosis. But what you can do there is use ultrasound shear wave imaging, where you're actually using, I remember I showed you the strain for the aortic aneurysm. It's similar technology. Here you're getting shear wave images out. So where the shears is a high, you can say, well, that's fibrosis. And this other thing where we're getting a backscatter signal is fat. So you can tell how much there is in a given patient. Again, it's an embryonic technology. We do some modeling and simulation. As a matter of fact, this whole program we call the IMAG program, which is all modeling and simulation. And if you want to visit, it's IMAG. And we do computational fluid mechanics, we do biology. And here, Ashant Sameh, who's the current president of the Association of Medical Physicists, the American Association of Medical Physicists, has actually taken all organs and built true phantoms out of them. And you can actually study radiation that goes to each phantom on Earth, right? So then he was asked by NASA to create a male and a female organs to send up on the last Artemis mission, where they actually measured what kind of radiation these organ phantoms would get. This is the first time read, and so it is still looking at the data. I think it's only a couple of months old, but it's not. So what we do is not only applicable here; it's applicable everywhere. But obviously, the main application here is radiation therapy. So from that, and I think you do. I think you do mixed reality here, where you're looking at while you're doing surgery, you can superimpose an ultrasound image on it, or CT or MR image, whatever you want, So you know exactly. But the reason is, especially in breast imaging, where the patient lies down on the bed for the surgery, it's the tissue deforms. It's nothing like when you did the mammogram of the study. So you want to be able to correlate that, and you can do that with this virtual reality. And this brings me to the end of my lecture, if I haven't bored you enough already. And we just started a medical imaging and data resource center in the at NIBIB. Now, remember I told you about the White House meeting? We had these people come and we said, okay, well, we need a place where we can do all of this. But how are we going to do it? We needed a use case, as we call it. And nobody was going to just give us money for, trying something. So, unfortunately, COVID-19 showed up. And the U.S. government at that time released a lot of money for the treatment and also for research and finding out. So we got a chunk of that money, and what we said is, okay, we're going to start this idea we had of studying all kinds of medical images and all kinds of diseases. So it's not just medical images, but we want to also interoperate with EHR or lab data, whatever data, EKG data, whatever you have, EEGs, and then so we get a better diagnosis. If I do a brain scan, it's not what I see, but also incorporating what the other studies are saying. So we want to get there. In the meantime, we got COVID, so we said, let's start building it. So we gave a contract to the University of Chicago, and it's run by Mary Ellen Geiger, who's world famous and accomplished AI physicist. And this contract was given to the Association of Physicists and American Association of Physicists in Medicine, the American College of Radiology, and the Radiological Society of North America. The idea was to bring in images from wherever. The ACR has access to all images all over the country, as does the RSNA. RSNA is more international. They come into one place at the University of Chicago. They cleaned up. I'll show you a better version. And then they are made available to the public as clean AI, trustworthy data that you can do AI algorithms on. So this is an open discovery data commons where we will create what is needed for testing and quality assurance of this data. And then we also support medical intelligence computational capabilities. Now, this has grown a lot in the last 2 years. It's only 2 years old. So so far there are 309,000 studies. A study is like a CT scanner will have hundreds of individual images in it. So far, the 135 images have been released. And when they release, they're de-identified. You don't know who the patient is. They're curated, so they make sure this is a chest X-ray. So sometimes you'll get a chest X-ray marked as a knee exam. Obviously, that's not true. We do the quality control that's needed. We annotate it, meaning to the extent that we can tell. We will say whether it's normal, what kind of pneumonia is it, etc. And it's harmonized for computer-administered purposes through the LOINC, which is RSNA, another RSNA invention that NIBIB paid for. So then we have 27 algorithms in development, 135,000 imaging sets, which is about 60,000 patients. We'll release 80% of them are released on a public commons. Anyone can use it for doing AI, ML, fair, trustworthy, representative, and searchable. I mean, it has all the qualities you'll need. The other 20% we sequester, and we worked with the FDA to say, we're going to hide these. So if you create an algorithm and you want it tested, because nowadays the FDA, I was talking earlier about regulation, it's always interested in artificial intelligence in devices. Now it's interested in artificial intelligence in medical imaging. And this is called software as a medical device. They have a whole new policy. So if I create an AI algorithm and say, I can tell you this is TB, well, let's say, okay, show us, and of course you'll show your data, and then they'll take your algorithm and they'll test it on something like this, okay, and then they'll say, well, we trust this because we created it ourselves with the NIH, and your algorithm doesn't quite do what you're doing. Also, one of the things you got to remember is, I create an algorithm, I might have used data from 2018 to 2020. where there was no COVID, right? And then suddenly there's COVID, and then it disappears. So if I developed an algorithm for COVID during those 2 years, it may be very different from something I create later, or because the prevalence of the disease is changing. So all of that has to be monitored, and that's what this does. So we have 54,000 patients, as I said, but this is just the data size. That doesn't. We have about 500 users, 100 clear-cut investigators, about 350 collaborating institutes around the world. So far, about 40 publications and several presentations. Now, when we were designing this, one of the things we did this even before these articles came out at MIT Review, and that is, a lot of people were using COVID data unclean. Nothing was being done, and they were publishing, "Oh yeah, we've got an AI system for COVID," and none of them worked. And the reason was the poor quality of the imaging data. They were mislabeled. There were multiple unknown sources. You always need to know, it's called provenance. You have to know where your images came from. There was duplicate data. There was no traceability. You couldn't go back and say, what year did the scan get done? And lacked external validations. It was often only one person reading the image. And so there were many things that were wrong with it that we proactively kept out of MIDRC. So one of the things that MIDRC does is there's a lot of self-study, and we address bias and diversity in data sets. And you, for example, you can use this URL, can go, if you've doing an algorithm and you want to see if you're doing the proper things in terms of bias and diversity, you can actually go there, and it's free. I mean, they'll tell you how to do it, and you can correct your own system. And there's a lot of hands-on help from them. They also monitor the kinds of data to reduce bias. Which part of the country did it come from? Were they rural? And of course, we have to get those people included as well. Otherwise, your data is not worth it. So just like in any scientific paper or study, when you do an AI algorithm, you have to say, well, I studied patients from this year to this year, mostly from Arizona, mostly from this hospital or setting. So that way, at least you know that you're correct in that context, and it's not universally applicable. So I would like to see a universally applicable AI algorithm, but I think it's going to be a while before we do that. But here they're monitoring, for example, race, ethnicity, COVID positiveness, sex, and age, of course. And they do it over time, so that if you want to sample at any given time, you know exactly what kind of patient you're getting during that area. And this is important if you're going to have anything useful. So finally, once you've developed your algorithm, you've got to give it some structure that people can believe in, and it's got to tell you exactly what it's going to do for people. So if you go to the MIDRC site, they will actually help you measure all of the attributes that your AI algorithm should have, and they can tell you where you're deficient, where you should do better, and where And right now, all of the images in MIDRC are COVID-based. So they've even got some studies where they've looked at patients, they assess severity, and they can tell you whether a person is going to need an ICU bed in 24 hours or not. Very useful information, and it's very useful because of costs involved. And that would be whether this patient not in 24 hours, but whether they'll be subsequently needed in the next couple of days. Another thing we found, with all the care that we took, that is these images, a patient will come and say, I'm in such and such a race. No big deal, you already know that. But the computer can look at the images, even the worst images you give them, and it can tell the race of the patient. Now, we don't know where that's coming from. It's somewhere in the voxel. There's no data given at all. And Judy is part of the, she's an interventional radiologist at Emory, and she's also a data scholar at NIBIB. And so this is already out. It's in Lancet Digital Health, got a lot of press. So now people are seeing how are these images able to tell race just on horrible images. I mean, you know, how are these algorithms able to tell? It's not just a self-reported. Who cares if you're self-reported? Now, what we've done with MIDRIC, again, only COVID data, is we've linked it and made it interoperable with the electronic health record that's available at the National Cancer Center for Advanced Technologies at the NIH. It's called N3C. With NHLBI, they have a biodata catalyst with EHR and images, so we can work with them. This is very important because if later on, I don't think any single repository is going to be able to hold all the data, so they've got to talk to each other. That's one of the main foci right now in the US government. And we have also a All of Us program that you might have heard of. It's 1 million patients, and we're slowly looking to be their medical imaging center. So as I was saying, I mean, acute COVID has certain things that you'd be interested in. We learned that from long COVID can affect every organ. So we've also collected images, but we've done nothing about that except for the chest. So our next focus is to create a system, which is happening right now, where the tools and the knowledge bases and the data are either sitting in one place, which is probably a dream, but can be easily linked together so that you can interpret the image you have. Or maybe you're just a pathologist looking at cytology and you want to know if the radiology correlates with that. So that's also useful for you that way. So the white parts, the blue parts are the ones that MIDRIC has already done in this idea of what we call it SEAM. It's a sustainable ecosystem for medical, for artificial intelligence in medicine. And we're working on it. Nothing has happened. There's something going on at the government level that I cannot speak about yet, but we hope to accomplish it. So in short, the vision of NIBIB is to engineer the future of health, okay? So we think that eventually there'll be continuous monitoring analysis of various sources of health data. You may have wearables. You may go to a doctor and have a CT scan in July and another one in December. You may start an exercise program, and all of that you should be able to put into one place where you can continuously monitor your health. So the way we think is health is not something that you only get checked when the doctor sees you. It should be something that happens continuously, and that we should be able to predict your risk earlier rather than later. So that's where we're hoping to head. And I'll finish by just saying that we are interested in image quality, with thinking of how we can extract the best information out of these images. We're rethinking acquisition strategies and therapeutic strategies. We want to integrate the various sources of health data, and we think we're getting ready for the age of artificial intelligence, whatever it is that's going to offer us. Thank you very much. Hope you didn't get too bored. You have any questions? Thank you.
Tenéis micrófono en los asientos si hay alguna pregunta.
I've never stunned audiences before.
Thank you very much.
Oh, yeah, you're quite welcome. Please do come to Washington. That's our cherry blossom week in Washington. So thank you for having me. It was a wonderful experience. Thank you.